So let me remind our audience that when it comes to prescribing of opioids, there are some patients who are not candidates for opioids. So let's think about that from a couple of fronts. From a long-acting opioid perspective, obviously you wouldn't want to start some of these agents on someone who's opioid naive. As a matter of fact, there are two agents, sustained-release hydromorphone and transdermal fentanyl, that the package inserts strictly say these are not for use in opioid non-tolerant or opioid naive patients. So I think it's important to kind of recognize that to use these medicines safely, you need to start at the lower doses and titrate upwards over time. Let's briefly talk about treatment success. I know we all mentioned in some fashion function, monitoring patients of function. Obviously, pain relief has to be a goal. Does anybody have any criteria for treatment success? Vitaly, how do you address that?
Well, when Chris was mentioning obtaining informed consent, which I think is really crucial when establishing relationship with a patient, he mentioned function. We spoke earlier that function is the key component of assessing the efficacies of prescribed opioids. If I don't see any improved function, if the patient continues to lead inactive lifestyle, I would question the patient why it's happening, whether maybe there are some significant side effects that were mentioned earlier that preclude that improved function. I also look for frequent calls to our practice, running out of the prescription early, dose escalation and things like that. These are some red flags that I would use initially when assessing the efficacy of the prescribed regimen.
Hey Joe, what do you do if your patient wants to continue opioids and in your opinion, they haven't had success to that point?
And I think it's very hard because again, it comes down to their perception of care. And what I try to do is again, rely on that careful documentation that I mentioned. That documentation is not just there for medical legal reasons. It's there as a living testimony, a dynamic resource when you're having these points of bargaining with your patient. To say, hey, look, look at this body map. Look at this list of things that we want to achieve. Where have we gotten? And objectively place it in front of your patient because they have to have buy-in. And you want to be respectful of the fact that they may have a different perception, but when you objectively show them, hey, we really haven't gotten better, and that's where I think it was very important that it was mentioned by all of us that don't go by the number. Because they may say, well, I still have pain that's 8 out of 10. Well, what does that mean? You're right. How many times have you walked in, your patient, how are you feeling? Oh, my pain's 7 out of 10, yet they jump out of the chair and hug you because they're happy to see you. So I think you have to objectively define it, and you sit down and you say, look, this is where we were, this is where we are now. I don't see meaningful improvements in activities of daily living, functionality, or quality of life. And so now we have to think of new alternatives and alternative strategies. And I think also at that point in time, if they haven't seen a psychologist, this is where we want to bring a psychologist in. And I think it's important because I think one issue sometimes that we deal with is immediate gratification. Patients want to try to have immediate gratification for a lot of reasons. Some are good, some are bad. And we have to have coping strategies. So either you're going to set those with your patient or you're going to have a psychologist or psychiatrist set these coping strategies up. The earlier, I think, the better. And this way you can objectively monitor their progress.
Of course. And